Okay, last chapter, chapter 15. This is a good chapter to end on because it gives us a chance to review the paradigms of psychology that we've been talking about ever since chapter 1. So we got the psychodynamic paradigm, the humanistic paradigm, the behavioral paradigm, and the cognitive paradigm, and how they practice therapy, how their principles and major concepts get applied in the therapeutic context. And of course, this is a good chapter to follow the mental illness chapter because many of those people we talked about in the last chapter with mental illnesses are going to need one or the other of these types of therapies. All right, so what we're going to do is, let's see, here's the four that we're going to cover. What we're going to do is we're going to cover a few things about each one of these. What do they believe is the cause of pathology or the cause of mental illness? What's the goal of therapy? What are they actually trying to accomplish during therapy? What are the specific methods that they use? And what's the role of the therapist? Mainly that centers on the question of if the therapist is more like a coach and a facilitator, or if the therapist is more directly involved in making the change happen during therapy. So the role of the therapist, and then the last thing we'll cover in each type of therapy are some other issues. All right, so with that in mind, let's start with the psychoanalytical paradigm. Now, I'm thinking that because of what you know about Freud, psychodynamic theory, psychoanalytic theory, that you could fill in the blanks that I just gave to you a second ago on your own. For instance, if somebody comes to you, if you're a psychodynamic therapist, somebody comes to you and is talking about depression, the things we talked about in the last chapter, lack of energy, feeling a sense of hopelessness, no motivation, inability to experience joy in things that this person normally feels joy in. If you're a psychodynamic therapist and you hear that from a client, what are you thinking is the cause of pathology? Where do you think the root of the problem is? Now, I'm thinking you could fill in the blank as I suggested, but go back to that iceberg analogy that we talked about in chapter 11. Only the tip of the iceberg is what is consciously apparent to each of us. Most of our psyche, most of what's going on within us that causes most of what we do comes from the part of the iceberg that's underneath the water, the unconscious part of our personality. To a Freudian, that's where the problems are. If somebody is depressed and describing those kind of symptoms I just described, then you're thinking that what they're able to tell you is just the tip of the iceberg, but the real problem is underneath. So the cause of pathology would be unconscious mental conflicts. There's something going on underneath that the person is not able to, initially at least, able to articulate and describe and understand. So that means, that would suggest that the goal of therapy then is to uncover the unconscious, to make sure that we can get into the unconscious and figure out what is going on in there in the past, in the way the person is reacting to things now, perhaps that relate to things that happened in the past. We need to get into the unconscious. But if you just get into the unconscious and make what is unconscious conscious, chances are it's going to be repressed again. The reason why we repress things is because it creates these things when we are made consciously aware of them, they cause us tension and conflict and anxiety. They're uncomfortable, and so we're constantly trying to shove that back down, shove it back underneath the water. So in order to keep things conscious and keep, maybe a good way to look at it, keep things moving back and forth between consciousness and, say, a preconscious, and the unconscious, then we need to reduce repression. We're probably not ever going to stop repression because a certain amount of it is probably healthy. It's human nature, but we want to reduce it, slow it down a little bit. Otherwise, we have this revolving door. Things get brought into consciousness, and then they get shut back down, and then we may bring them back out into consciousness again, but then they get shut back down again. So we have to stop the cycle. Another way of looking at this second goal of therapy, I didn't mention this actually in the last chapter, but I want to highlight it now. Remember we said that one of the myths about the mentally ill is that they're dangerous. The research says that the vast majority of violent things that we observe in the world are committed by sane people, by mentally healthy people. Maybe they're off a little bit, maybe they have anger issues or something like that, but they're not really diagnosably mentally ill. One of the reasons why they're not mentally ill, excuse me, I didn't mean to say that. One of the reasons why, according to Freud, one of the reasons why they're mentally ill are less likely to be violent is because they're too busy repressing their unconscious mental conflicts, keeping them underground. That takes energy that could proactively be used to deal with the world offensively. Depressed people, anxious people, mentally ill people, they tend to act to the world defensively instead of offensively. They're not proactively doing mentally healthy things because they're so focused on their depression, their anxiety, or whatever their mental illness is. And so I did say this in the last chapter, because they're so focused on that, they have a hard time mustering enough energy and the cognitive capacity to be violent towards other people. So when we reduce repression, what we're doing is we're allowing them to be more proactive in dealing with the world, because the less energy is now going to be devoted to shoving stuff underground. And that's a good thing. Maybe humorously, on the side, maybe that makes them more likely to be violent toward other people, because now they may have the energy and the cognitive capacity to be violent because they're freed up from constantly repressing things. But generally, of course, we would say that reducing repression is a good thing. Now, the third goal, if you are a traditional psychoanalyst, is to restructure the entire personality. So if you were Freud, or you were your grandfather, who was well steeped in the psychodynamic and psychoanalytic way of doing therapy, you would not only want to uncover the unconscious and reduce repression, but you would want to go back into childhood and recreate all the events, all the experiences and the emotions that were part of childhood that led to the current state of dynamic interactions between those three components of the psyche. And in doing so, you would try to, in a sense, restructure the personality. Now, let me just put a little caveat on that. Freud actually believed that this type of therapy was best thought of as being insight therapy. The best that you could do with your unconscious is gain insight into it. You can gain insight who you are, but you can't really change who you are, because remember, the child is the father of the man. The first 5 years determine the rest of your life, and there's not a whole lot you can do about that. You can gain insight into who you are, but you can't really change it. So this phrase, in the last goal, to restructure the entire personality, is kind of a misnomer, because according to Freud, you can't really truly restructure the entire personality, but you can gain insight into how everything gets related to each other, and that's helpful. In a similar way, if I can't change my wife, and that's actually true about people in any relationship, you can't change the other person. If you can't change the other person, then how do you get along? Well, you get to know each other to the point that you have insight into, what the triggers and whatnot that create problems in a relationship, what they are, and so we tend to be better able to walk around them, tread lightly around them, and to deal with them because we're aware of them, and we have insight into what happens when we're not aware of them, and encroach upon territory that creates problems. So in that sense, if you understand that, Freud believed that therapy was basically insight therapy and not really a total restructuring, although the idea is with this, you go back into the person's childhood to get a better feel for what happened when and how that would explain the way the person is now. And in a sense, what you're doing is you're restructuring how the id, ego, and superego are going to relate to each other based on that insight of what's happened in the past. Now, I mentioned this as a traditional goal in psychoanalysis because it's not done so much today, since it requires going back into the past and taking a lot of time, spending a lot of money, and because a lot of patients today in therapy don't want to take the time and spend the money, don't see the value in it maybe, and there may be comparative shopping. They're comparing this therapist with that therapist in relationship to this particular problem, and this therapist says, you know what, I'm a behavioral therapist or a cognitive therapist, and I really believe that we could probably get at the heart of your problem and give you some guidance that will begin to improve your life within a matter of 2 or 3 or 4 visits, maybe at the most. And it's going to cost you X amount of dollars for those many visits. So you hear that, and then you go to this other therapist, the psychoanalyst, who says, well, I believe that you really should come in twice a week for the next several months so that we can truly get into your past and delve into all the symbols of your life and get a grasp on really what's gone on to lead you to this point. And then after that, the best thing to do is to keep coming back once a month or once every so often for several years. That's kind of a continuing education kind of a thing. That's the way traditional psychoanalysts who want to restructure the entire personality in a sense through insight, that's the way they look at it. They want you to come back to therapy quite a few times. And when you compare that to what the behavioral therapist or the cognitive therapist wants, or even the humanistic therapist wants, then you're more likely to go see one of those types of therapists than the psychoanalytical therapist, which is the reason why many psychoanalysts are not using that third goal so much anymore, even though the principles of the therapeutic practice suggest that you really need to go back in the past. They're doing it less and less today because the market just won't bear it. People just won't do it because they know that they can do another kind of therapy that is a little more directed specifically at the current problems and focuses less on the past and will cost less money and take less time. I kind of think those psychoanalysts that are abandoning that third goal are kind of selling out to a certain extent. And the purist in me says that's not okay. But the practical person in me says, I kind of get it. You have to be able to survive and do what's best for your clients. And if they're not going to come and see you and pay you money, if you're so stuck on going back into the past and taking tons of time, then you need to change. So I kind of get that, but it does still seem to me like they're selling out a little bit. We call these new psychoanalytical therapists who focus less on that last goal, we call them short-term dynamic therapists. Short-term dynamic therapists are psychoanalysts who just tend to have gone away from that last goal to a certain extent. So that's the cause of pathology and the goals of therapy. What are their methods? Now, first of all, before we actually get into free association, I want to mention that Freud has long been interested in dreams. One of the first things that put him on the map, so to speak, in psychology was his publication of the book Interpretation of Dreams. He long believed that dreams were the royal road to the unconscious, and that's the way to get into people's psyche, to gain insight into who they are. Why? Because when we're dreaming, our defense mechanisms are down, and the things that are in our unconscious may slide up into consciousness and provide some ventilation or freedom of movement of those things. In a sense, you can imagine in that iceberg analogy where you got the conscious personality up here and the tip of the iceberg and the unconscious personality underneath the water. We have a door there, and what happens during our daily hours is that we don't like things moving up from our unconscious to our conscious, and so we keep the door shut. But we know that the door is a little leaky, that is prone to fly open, and so we need to put our weight against it, because there's this seething cauldron of psychic energy under the water that is seeking escape. And if we're not putting weight against that door and making sure that it stays shut, then this stuff can sneak out, and that creates problems. We don't like that, so we put a lot of weight and effort against that door. That's what repression is, that causes us to not be proactively dealing with the world, but to be defensively dealing with the world. So when we're asleep and our defense mechanisms are down, basically, in a sense, we moved away from that door, and the door is allowed to open up a little more freely, and stuff comes out. Now, it comes out symbolically, and so it needs to be interpreted by the expert psychoanalyst, but it comes out. That's the good point. That's the most important point. Now, Freudians still use dream analysis. Symbolism in a person's life are still very important to a psychoanalyst. But if you think about it, there's an issue here. Basically, in therapy, if you feel like what the person is telling me is just the tip of the iceberg, so I need to get them to move away from the door a little more to get some insight into what's really down there under the water. Basically what that means is I need to get them to go home, I need to get them to sleep, I need to get them to dream, I need to get them to report their dreams to me. Everybody dreams every night. I'm not sure that we really covered this extensively in Chapter 4, but I want to make the point that some students say that I don't dream, but everybody dreams every night. You just don't remember them. In other words, everybody has REM sleep in which our brain is very active, where these more visual and plot-related dreams are occurring. Most of the time we don't remember those, and sometimes we just remember enough to truly make them truly bizarre to us. But everybody dreams every night. But most people are not very good at recalling their dreams, and even if they recall them for a short time, they'll forget them within moments after waking up. And so using dreams as a source of analysis, things to analyze, creates a kind of an awkward situation in this kind of therapy. Freud decided then that maybe what I can do is I can get them to be relaxed in another way that doesn't require sleep. And that's what free association is. If I can get them to be totally relaxed, get them to move away from the door, and have them engage in a stream of consciousness where they just talk in a very relaxed manner about whatever comes to mind, and not shield anything from me as a therapist, then eventually some of the things that are in the seething cauldron of psychic energy underneath the water are going to seep up into consciousness, and they're going to come out. And when they come out, I'm going to be able to zero in on them, and we can talk about them. So free association, this is Freud's house in London. Free association is done this way. The patient lies on the couch. So it's a study in Freud's house. It's not a clinical office that might be inhibiting, that might lead the person to not be totally relaxed. The person is lying down rather than sitting in a chair, which again causes them to be likely to be more relaxed. They look around the room, and you can't really see it in the picture except for in the background there. There's some artifacts that Freud had gathered from garage sale type places throughout his life, and that some of which he gathered from digs he went on, archaeological digs. He has these artifacts all over his house and in the study where he's doing therapy. And as the person is lying there and looking around the room, they may see these artifacts, and these artifacts are drawn from burial sites and important sites important to people. These sites included artifacts related to death and life and birth and relationships. And so Freud thought that these things were kind of archetypal for important issues in human existence. And as people are free associating on the couch, they're going to look around and see these things that were important to humanity over eons past, and it's going to trigger in their own psyche some of their own issues related to life, existence, relationships, death, birth, religion, belief in God, and so on. And those things are, when they trigger these things in their own psyche, then it's going to help them further get into and discuss things that are going to be important to their mental illnesses. Now, I want to point out here, while the person is relaxed and, in a sense, moving away from that door so that it can open up, the person is not even seeing the therapist, because the therapist is sitting behind the couch over here in the therapist chair. The therapist might actually say, look, I just want you to talk and relax and just say whatever comes to mind, and don't even think about the fact that I'm here. And to help you not think about me, I'm not going to say anything. I just want you to talk. And eventually I'll get into what you're saying, and we'll then zero in on important things. But for now, just talk and talk and talk. So you can see how free association is related to dreaming, getting the person relaxed and moving away from that repression door. You've seen portrayals of free association in the media, movies and whatnot, and oftentimes it's portrayed as the therapist says a word, the client says another word in response. Immediately the therapist says another word, the client says a word in response to that, and it just goes on in this kind of tight, mechanical, quick reacting kind of a setting. And that's not free association at all, because there's no relaxation, there's no stream of consciousness, and it's actually, in that portrayal, triggered by things the therapist does and says. But in this context, free association is a very relaxed environment in which the person just lets go of this stuff and starts talking about it. I want to point out something else, that Freud also used hypnosis. To his credit, he abandoned it early on. But if you think about hypnosis, it's kind of a similar kind of a thing related to dreaming and free association. It's an attempt to get the person relaxed so that the person will move away from the door, repression door, so that things can seep into consciousness and then they can be dealt with. The reason why Freud abandoned it is because he realized, as we talked about in class, that it's a heightened state of suggestibility, and the therapist can actually suggest things, maybe inadvertently, that the person will incorporate in their analysis of them things, which may be bogus, that may not actually be reflective of important issues in the person's psyche, but may just be a reflection of the fact that the patient is incorporating into what they're saying things that what the therapist suggested. And so that's a problem. It's not really objective, and it may be involve too much direction from the therapist. So Freud was very directive in other ways, and he was roundly criticized for that by some other therapists. But he recognized that hypnosis was a means of the therapist perhaps being too directive to the client, and thus getting in the way of a true reflection of what was going on in the individual psyche of the patient, as opposed to what the therapist wanted the patient to get into. So he saw that as problematic, and he gave it up. All right, so free association is the first method, major method of Freudian therapy. But the point here is that when things move into consciousness, the person is going to feel uncomfortable and not really enjoy talking about certain things, because they create tension and conflict and anxiety. And so they're going to resist against these things. And that resistance is going to be manifested in terms of changing the subject, not dwelling on it, and maybe at some point when the therapist asks, what is that? What do you think that means? And asks the person to try to get into that a little more, the person is going to begin to physically look or act uncomfortable and tense in relationship to talking about those things, and again may change the subject and resist talking about it. And those are signs that, to the therapist, that we've hit upon something important. So whenever there's resistance against talking about any particular thing, the therapist, the psychoanalyst, knows that that's what needs to be talked about. That is something that is is holding a lot of psychic energy, and that needs to be released. That energy needs to be released from that. So we need to talk about that. The third tool that psychoanalysts use is called transference. Transference is both simple and complex. The simple part of it is that in any relationship, who I am, for instance, in that relationship is going to come out in that relationship. If I'm a particular kind of person with this kind of personality, these kind of quirks, then eventually the more relaxed I am, the more I am comfortable in this relationship, the more likely that part of me, those parts of me, are going to come out in that relationship. In other words, I'm going to transfer who I am into that relationship. So Freud believed that the client-therapist relationship was a relationship like any other, in that if you can get the person to feel totally relaxed and comfortable, they will transfer more and more who they are into this relationship. And then the therapist can use that as a window of insight into the client. Whatever the patient does, however the patient interacts with the therapist, is a window of insight into what's going on into the psyche of that person. Let me just use another example. If I'm a racist, the more I get to know you, the more comfortable I am with you, the more likely at some point the fact that I'm a racist is going to be portrayed in this relationship, and you're going to figure it out. Freud believed the same thing about therapy. Freud also further believed that the therapist, the patient, will often treat the therapist in the same way that the patient would a significant other, like a parent. And so that gives the therapist insight into how this patient may have interacted with mom or dad in the past, which again gives further insight into some of the past issues that have shaped the way the person is today. So let me ask you this question based on that. If you're a psychoanalytical therapist and your patient falls in love with you, is that a good thing or a bad thing? Now, at first glance, you might say, well, that's a bad thing because it leads to the lack of objectivity in naturalness in the relationship at first, particularly, you know how when you go on dates and you're super nice and you're super great and you're putting on the best face and your best foot forward, it's a little bit false, and so that wouldn't be good if the patient falls in love with the therapist. That means that the patient may be a little bit false, and the therapist will get a false readout on what's really going on in the psyche of that person. And then there's the issue of what we call countertransference. If the therapist falls in love back with the patient, that would not be a good thing, right? And so then you have a totally muddled, confounded relationship, and therapy is going to be hard. Those are the negative things. But the good thing is that if the patient falls in love with the therapist now knows something about the patient that he or she didn't know before. The therapist needs to look at it this way. Wow, this patient is falling in love with me. Now I know that this is that type of person. This person is the kind of person that would fall in love with somebody like me. Maybe the reason why she loves me is because I'm a father figure to that person. And let's explore that. Not in an unethical or inappropriate way, but let's explore what is it about me that relates to the client's father. And then I can get a better understanding of how this person as a child related to father and how that relates to some of the personality characteristics that this person has now. So if the patient falls in love with me, okay, may complicate things, but now I know something I didn't know before. If the patient gets angry or defensive or stubborn or anything, then I now know something that I didn't before. So I'm going to use how he or she treats me as an understanding of this person. Now, countertransference is not good. You don't want the therapist's psyche baggage to get in the way of the therapist's ability to gain insight in the client and treat the client. So how do you stop that? You can't have the therapist falling in love with the client. the therapist getting angry at and defensive and stubborn and all those sorts of other things in relationship to the client. So how do you stop that? Well, Freudian therapy is really unique in this. When you go to train to be a psychoanalyst, you take some coursework and you learn some academic type things, but you spend most of the time, and of course you also will be mentored as you're counseling other people. So you'll counsel somebody and then you have a mentor helping you to see how you could have improved this interaction and that interaction and what things you could do to make it better. But more so than that, you spend more of your time in training as a psychoanalyst on the couch. You get more time in therapy than you do learning how to be a good therapist, partly because the idea is that when you are mentally healthy and in touch with your unconscious and you understand who you are, then you're going to be a better therapist. And who you are is going to be less likely to intrude upon the interpretations that you're going to make of your client's psyche and the help that you're going to give that person. So, again, I say this is kind of unique. Most other types of therapy don't require their therapist to have as much therapy as psychoanalysts do. Okay, so the basic concept here is a lot of interpretation. Through free association, resistance, and transference, the psychoanalyst is interpreting what's going on in the psyche, because all of this is symbolic of what's going on in the psyche, which basically makes the therapist a true interpreter and gives the therapist a lot of power. So we would say that the Freudian therapist is very directive, and on the scale of how much power is given the therapist in order to create change and to make it happen, there's a lot of power given to the psychoanalyst. There's a continuum of directiveness in therapy, and you can range from being very directive to being very non-directive, and Freudian therapy is more on the very directive end. And this is the kind of thing that Carl Rogers, a humanistic therapist, criticized Freud for immensely, and psychoanalytical therapists in general immensely. He said that therapy should not be therapist-centered. We should not give that much power of interpretation and guiding what's happening here and what things mean to the therapist. We should give the power back to the client, leave the power with the client, and therapists should just be facilitators and coaches and let the client interpret things and decide what things mean in general and what needs to be done. In a sense, he believed that therapist-centered therapy, which is what he called Freudian therapy, made the therapist God and relegated the client to somebody who was ultimately powerless to help themselves. And that's, of course, that's not consistent with the humanistic ideas at all, because they believe that people are naturally good and naturally will do things that are best for them if they're just allowed to freely choose behaviors and actions in their lives. All right, so because of that, Carl Rogers created his own type of therapy, which he called client-centered therapy, which we'll talk about in a second. So some other issues here are that, particularly if you're a long-time dyed-in-the-wool traditional psychoanalyst and you want to go deep into the past and completely analyze relationships with mom and dad and everything that happened in childhood, it can be very time-consuming. I once heard about a therapist that over 20 years of practice had 39 different patients, which, where I read this, it was meant to be an indication for how time-consuming it is between a client and a therapist. The therapist spends a lot of time with each client, so they can't have a whole lot of clients because they're spending so much time with each one. When I told this to my sister-in-law that I'd read this, my sister-in-law who became a psychoanalyst after many years of being a clinical psychologist, she said, that's about right. And I was actually pretty surprised that she didn't think that was extreme. I thought that was very extreme. And she actually told me when she was going through therapy in her training to be a psychoanalyst that she would spend a couple of hours, maybe minimum, a day in therapy. And she happened to be in Utah training to be a psychoanalyst, and her mentor was in back east. And so they would do virtual therapy. She would lay down on the couch and relax, and then he would communicate with her, and she would communicate with him via some kind of Zoom technology or something like that. Okay, if it's very time consuming, it's going to be very money consuming as well. Now remember, this is insight therapy. Insurance companies are very disinclined to pay a lot of money for insight therapy. They're more inclined to pay for medications, which creates a problem. One of the reasons why medications are prescribed so often, and they become the center of a lot of treatments, not only because they do work to a certain extent and they're quick and easy, but insurance companies are more likely to pay for them, less likely to pay for this kind of therapy. So if you're paying for this out of pocket because insurance won't pay for it, and you're going twice a week, say for a year, and it's costing you $300 an hour, $600 an hour, $600 a week if it's twice a week, and you go 50 weeks, how much is that? 600 times 50, that's $30,000, right? A lot of money, which is another reason why a lot of people are not going to psychoanalysts these days, particularly the non-short-term dynamic therapists. They're going to somebody else. You have to also consider that psychoanalytic therapy requires a patient that's pretty verbally skilled and coherent, has the ability to talk about subjective and ambiguous things, to get into all sorts of feelings and interpretations of dreams and symbols in people's lives. It requires somebody who's pretty deep, which means that, and logically coherent, which means that a schizophrenic or somebody that's really fragmented in terms of their thought processing, so take again a schizophrenic or a borderline personality, or somebody who suffers from severe depression or severe manic depressive illness, they're probably not going to be prime candidates for this kind of therapy. It's not really going to work very well for them. And I would argue even to a lesser degree, if you're dealing with the typical black and white bean counter type of personality, and they're just not very deep. And I know a lot of people that I count as friends that are decent people and successful, but they're just not all that deep. They probably would not be good patients for a psychoanalyst, because when it comes down to free association and letting go with the stream of consciousness, they talk about a few black and white things and that's it. The well is dry and there's nothing else to talk about. Well, they're not going to be good patients. So anyway, this type of therapy is really for certain types of people. People with money, people with a lot of time, and people who really want to explore their psyche and want to and are capable of getting into the depths. All right, that's psychoanalysis therapy. Let's move to the next one. So as I mentioned, Carl Rogers believed that Freud had it all wrong. It gave power to the wrong person in this relationship. And so he came up as a humanist with the idea that the real problem with people who are mentally ill and have issues that need therapy is not that they have unconscious processes that are creating these conflicts, but they're not self-actualizing. One of the reasons why they're not self-actualizing, not working at the top of the pyramid, is because they have a distorted sense of self. Their self-esteem is low. Their self-concept is vague and ambiguous and ill-defined. They're not real self-aware. Why is that? Well, probably because they've been in a world with parents and society and friends that has conditionally accepted them and has basically taught them that they need to be a certain way in order to be acceptable, to be loved, to be people of worth. And that causes people to put on masks, which are false, which are not really accurate portrayals of who they really are. And that creates confusion and anxiety and depression because these people are not genuine, they're not real. And so they need to somehow get an environment in which they are led to believe and understand that they are persons of worth no matter what, and they don't need to put on these masks. So the goal of therapy, I just kind of alluded to a little bit, is to help them to work toward the top of the pyramid by helping them have a more healthy self-image, helping them to stop putting on these masks, in a sense. So the methods are often referred to as active listening or reflecting. The way this gets stereotyped in the media in kind of a comedy scene is the patient might say, I'm just really depressed, I don't know what to do. And the therapist says, well, if I understand what you're saying, correct me if I'm wrong, you're just feeling really, really depressed. In fact, so depressed that you just really don't know how to put it into words. You don't know what to say. And then the client says, yeah, I can't motivate myself to do any schoolwork or to get myself out there and work hard to get the job that I haven't been able to get. I have no motivation. So then the client-centered therapist says, who's actively reflecting and listening, okay, some technical difficulties again. So the client is saying that can't motivate myself to do the things I need to do in school and work. And the therapist says, so if I understand correctly, you're having a hard time motivating yourself to do the schoolwork and to go out and try to get that job that you need. Is that correct? It sounds like a parrot in a sense. Why would you pay a therapist to just repeat back to you what you just said to them? It's kind of the question that arises when you see humanistic therapy, client-centered therapy portrayed in this way. But you have to understand what is being communicated here, according to humanists, is not words. You're not actively listening and just reflecting and repeating back words. You're trying to reflect the underlying meanings and interpretations. So there's a little bit of interpretation going on with the humanistic therapist as well, but just not nearly to the extent that goes on with Freud. So maybe like this. Maybe it goes like this. The client says, I'm just really depressed. I don't know how to put it into words. I don't know what to say. The humanistic therapist might say, okay, I hear you saying that you're so depressed that, so let's explore that a little bit. You say that you have a hard time putting that into words, but let's give it a try. Try to tell me a little bit more about what you feel. And so the client then says, well, I just lack motivation. I can't really muster the energy to go out and do my schoolwork and pound the bushes to get a job. And so the therapist says, so when you tell me focus on your schoolwork and getting a job, that suggests to me, I hear what you're saying here about your work and your schoolwork and your job. That suggests to me that your depression has something to do with and is related to what's happening at school and work. So let's explore that a little bit. Tell me some more about how you feel about that. And then the patient might say, well, I'm worried also about, given what's happening now, about my ability to get into Sac State or to UC Davis next year like I want, and that's depressing me and worrying me. So the therapist says, so I'm hearing that you're making a connection between how you're feeling now and your future. So you're feeling like this is going to start to shut some doors for you, and it's going to create problems for you down the road. And so that's a sense of hopelessness, perhaps, about the future. Is that what's going on? So again, there's a little bit of interpretation here, but the person is actually helping the person explore more. The therapist is actually helping the client explore more deeply the issues that they're bringing up, and maybe interpreting them and helping the patient understand them in a way that the patient doesn't understand these things at this point. Basically, through this process of reflecting back meanings and ideas and emotions relative to what's being stated to them, the therapist is not judging them, is not conditionally accepting them. As I said, many of us do to our kids and other people. We like them and love them when they do what we want them to do, but we don't really like them when they do otherwise. So we're conditionally accepting them, and that causes them to put on masks. And so since Rogers felt that was a real problem. He said the therapist has to communicate through this active listening process unconditional acceptance to try to counter all that conditional acceptance that's been going on in the person's life. There's no judging. The person is just validated simply for who they are. Whatever they say, whatever they express in therapy is taken without any judgment, without any, well, that's crazy, that's stupid, I wouldn't do that, without any guidance in a sense, because that also can be kind of a slap in the face and may lead the person to feel conditionally accepted. So you're communicating unconditional acceptance, you're communicating empathy. Maybe the therapist eventually finally encapsulates what the client is saying and describes it back to the client in such a way that the client says, wow, she really gets me. She understands me, and I really feel like that hasn't happened to me with my parents or my wife or my husband or anybody else for a long, long time. This is great. I'm feeling understood. At the same time, the therapist is communicating authenticity and validating authenticity. The therapist is genuine and expressing real human emotions and being a human himself or herself as a model and accepting all that genuine, authentic feeling related conversation and behaviors that are coming out of the client, accepting all that. And so this modeling of authenticity and validating authenticity contributes to the patient becoming more and more authentic, more and more real, less and less likely to put on those masks that we wear that hide our true selves. In a sense, it seems to me like it's almost like sprinkling magic dust on the person's head. When you actively listen and reflect without judging, with just validating, unconditionally accepting, showing forth empathy genuinely, and being an authentic person and validating authenticity in the person, you're spraying magic dust on this person, and the person's magically going to get better. And that seems sort of overly optimistic and unhelpful, right? But actually, this is very consistent with the humanistic view of things. People are naturally going to do what's best for them. They're going to make their own decisions, and those decisions are going to be healthy for them if they're just simply allowed to make those decisions. And as long as they feel that they're people of worth and valuable and validated, they're naturally going to do what's best for them. And when we try to force things on them, then they're just going to rebel. And so we need to just let them go, validate them, listen to them, help them to feel accepted, and they will naturally change for the better. All right, so I guess I'm trying to communicate to you that maybe it does make a little bit of sense if it's done the right way, that people actually are more likely to change on their own when they feel validated and loved and accepted, and when they feel like people care. And when they're given role models of authenticity, they're more likely to change than when they're not given those things and when things are forced upon them. Maybe that makes a little bit of sense. I want to go in a little bit different direction a little bit. Why do people need to go to a therapist to get that? Why don't they go to their friends? Well, possibly they don't have friends that do this for them. And I think that's true of a lot of us. We have friends that we count as friends, but they're not the greatest listeners. They're not, and maybe they just tend to give too much advice, and we don't really appreciate all their advice. Anyway, I think a lot of people really don't have friends that can be those true friends that listen and validate and accept and are genuine. And that's the reason why we go to the therapist, who is specially trained to be this way. And I guess I'm thinking also that you may want to consider whether that's an easy thing. Would it be easy to be a humanistic therapist who does these things? I want to tell you, kind of in the same vein that I was just suggesting, I know some people that would be terrible therapists because they just are not very empathetic. They're not really good listeners, and they're not really authentic themselves. my firstborn daughter, the difficult daughter I've talked about earlier in the semester, if she were to become a therapist, I would tell people not to go to her because I don't think that she would be a good therapist. Some people are born to be good therapists and naturally are. And if you're one of those, you know you are, because people tend to go to you with their problems because they know you'll listen and you care and you validate them. My daughter, first daughter, is not really that way. She's talented in a lot of other ways, and she can find her niche and has in other areas of life. Therapy is just not one of those. Some people believe that good therapists are born and not bred. In terms of nature and nurture, nature is more important in terms of being a good therapist than other things. And I think the research actually bears this out, that the best therapists incorporate these kind of principles. And it doesn't really matter if they have the best credentials, go to the best schools, have the best licenses or whatever, or even what kind of therapy they specifically use. If they incorporate these principles, they're more likely to be successful. All right, the role of the therapist is basically opposite of that of Freudian therapy. It's very non-directive. The therapist is a facilitator and a coach, not a person that directs what needs to be done, because that's going to be not effective anyway. Some other issues here are that most successful therapists use this kind of methodology. Now, it used to be when Carl Rogers first came out with this type of therapy years ago, people would put on their business cards, client-centered therapist. No one does that anymore, and the reason for that is because everybody who's a good therapist actually is a client-centered therapist. They incorporate these principles. And also I want to emphasize that if you have done a little bit of therapy, peer support kind of therapy through high school or in college up to this point in your life, and you received any training at all, chances are it was this kind of training, because this is basic to all types of therapy. Now, you may still argue it's a little bit subjective, and maybe you could do this on your own. And if you had issues, you wouldn't go to a humanistic therapist because you can do this on your own. But again, many mentally ill people, many people with mental health challenges don't have this either innately within themselves, at least at the time. They're not capable of doing this for themselves, and they can't go to peers and friends and family members to do this for them. So that's the reason why they need to go to a humanistic therapist to help them get this unconditional acceptance and authenticity model and empathy and so on. All right, let's move on though to cognitive therapy. Now, let me talk about the humanistic therapy in a little bit different way. Humanistic therapists believe that we need to focus on feelings, and the focus is on the self. So the cause of the problem is distorted feelings about the self. Cognitive therapists use the distorted concept as well. And only they don't, not talking about feelings, they're talking about belief systems and ways of thinking, and not about the self, but about the world. So the primary issue here is the reason why the person is depressed or anxious or mentally ill in some way is because they have distorted perceptions or belief systems about the world, about themselves as well, but the self is not primarily the focus. It's about the way the person perceives things that happen in the world. So the goal of therapy is to change those belief systems, change those perceptions. Now, moving back a second, Epicurus was a Greek philosopher back 2,000 years BCE. He said this, and this is a paraphrase: things are not the source of people's negative emotions or depression or anxiety. Things are not the source of or the cause of those. It's people's perceptions of those things. And another way of looking at that is that if that's true, oftentimes things happen to us. Things happen in the world that we can't change. We just have to learn how to deal with them. What we can change is how we deal with them. It's our perceptions and our belief systems about that C grade you got in psychology or whatever class. It's your perception about the fact that you can't work right now because of the coronavirus, or you can't have face-to-face classes, is your perception of that, how you interpret that, and how you believe about that, that really is the thing that's making you upset or distressed, or the opposite of that these days. So if we can just get people to perceive the world in a more healthy way, in a sense, one way of doing that, get people to put on rose-colored glasses, help them to see the positive in things and interpret things in ways that are less negative, less black and white in the way that the world is viewed, then people will be more healthy. That's the idea. So let me present to you the ideas of a guy named Albert Ellis. Albert Ellis was a cognitive therapist. Specifically, he called his type of cognitive therapy rational emotive therapy. He said in his book, The ABCs of RET, RET stands for Rational Emotive Therapy. In his book, The ABCs of RET, he said that behaviorists have sold us a bill of goods that has made it problematic for all of us as people and for all of us as therapists. They have told us that the world is all about stimuli and response. Sometimes behavioral psychology is called SR psychology, stimulus response psychology. There's a stimulus and then there's a response, and there's really nothing in between. So in his book, The ABCs of RET, Albert Ellis talks about those stimuli being antecedent events, like that C grade in the class, or the fact that you got laid off from work, or jilted, or you can't go to school now or you can't go to work right now because of the coronavirus. Those are antecedent events or stimuli, and behaviorists have taught us that those are directly causing our depression, our anxiety, our frustration, our sense of anger, and that's all there is to it. Simple equation. A causes C. Antecedent events cause consequences. But what he says, that's wrong. The truth is that these antecedent events work through our belief systems, and it's our belief systems that cause those consequences. If you get a C grade in whatever class and it makes you depressed, the reason why you're depressed is because of your belief about what that C means about you. Your belief that the C says you're worthless, or that you can't get into Sac State now or in the nursing program. But maybe those beliefs are incorrect. Maybe you need to massage and change those beliefs in order to change the consequence. If you're Albert Ellis, he was a very unique kind of tough love kind of therapist who believed that people hold on to these faulty beliefs that they believe are healthy and necessary for success and part of a goal-directed, motivated person's lifestyle. And so they cling to these self-defeating beliefs, these black and white kind of belief systems, to the detriment of themselves, all the while they're making themselves ill because of their black and white faulty beliefs. So since he believed that people cling to these, they need to be forcibly, vigorously handled in such a way that people kind of get hit on the head, in a sense of woken up to the fact that they're making themselves sick. So he would yell at his clients and tell them they're stupid. Look, you're blaming your parents, you're blaming your teachers, your boss, you're blaming the government, blaming Donald Trump, which may be true. Or you're blaming somebody else, but the problem is you. You need to stop and wake up and realize that you're the problem. Until you start realizing that you need to change the way you view the world, you're going to continue to be sick. So stop doing that, you idiot, kind of a thing. He's kind of like the therapist or the friend of yours that you know loves you and cares for you, but he does it in a real tough love sort of way, and he can get away with it, whereas somebody else couldn't, because you know that he really loves you and cares about you, and it's just his demeanor and style. So that was Albert Ellis's contribution to therapy, and he became really well known as a successful therapist, not only because of his personality and his style, but because cognitive therapy really does work. It does seem to really help to change people's views of things, to help them to be a little more healthy in the way that they view the world. Let me just mention that I used to teach Psych 370, Psych 370, which is human development, lifespan psychology. And in that class, I got a lot of nursing students because it's recommended class to get into the program, and sometimes it's required to get into a nursing program. And I would often get calls at the beginning of the semester, emails these days, from a student saying, I'm in your Psych 370 class, and I just want you to know that I'm in the nursing program, and I need an A in your class. Oftentimes it was more strongly than I'm hoping to get an A in your class. It's I need an A in your class. So oftentimes it was the next sentence or two was, tell me a little bit more about your class and what I'm going to need to do to get that A. Do we have extra credit? Is there an opportunity to, if I fall short in some way, can I do extra credit to get that A? How much writing is involved? What kind of tests and so on. And then we'd have some test or something down the road, and they would get most of the time these are good students, they're pretty conscientious and motivated, otherwise they wouldn't be trying to get into the nursing program. But maybe they fall short of that A by a few points, and there's panicking. Dr. Stewart, Professor Stewart, I told you I need an A in your class, and I'm not on target for that, so let's take a look at those questions on the test. This was a bad question, don't you think? And when they used to give short answer questions and it was a little more subjective in the grading, don't you think that this answer that you only gave me half credit for really should be a full credit answer? Anyway, they would kick and scratch and claw and dig for every point they could. And I wanted to tell them, you know what? In the words of Albert Ellis, you're masturbating. You need to stop masturbating. When you masturbate, you're saying, I must get an A in your class, Professor Stewart. I must get this person to like me. I must get this job. Or I must go to London this summer with my students. I was masturbating a little bit a few weeks ago, and I was pretty upset that my program got canceled. But now I guess I realize that was actually the prudent thing to do, to cancel that program, and we'll move on, and next year we'll go. Making lemonade out of lemons, so to speak. I used to tell these students, you're masturbating, you need to stop masturbating. That's a black and white way of thinking about the world. The problem is if you must have this, then what happens if you don't? How are you going to live with that? If you backed yourself into a corner that basically says that you have to have it this way, then that's a problem. You're awfulizing as well. These are all Albert Ellis terms. Stop awfulizing. This is not entirely awful. Your life is not completely awful just because of this. Intoleration is another faulty belief that Albert Ellis talked about. My life will be intolerable if I don't get to go to London this summer. My life will be intolerable if I get a C in this class, if I don't get in the nursing program this year. My life will be damned. Damnation is another faulty belief system. My life will be over, which leads to suicide if I don't get this. We need to stop these belief systems. I used to, in talking about this with a class several years ago, there was a nurse in the class, somebody who'd worked in nursing for many years, and she said, you know what, I can totally relate to this because the nurses coming out of the nursing programs these days are totally neurotic and anxious, and they're not good nurses. They're masturbating, they're awfulizing, they're engaging in damnation and intoleration. And that kind of thinking is counter to the kind of empathy and caring and personability that you need to display to be able to be good nurses. And so I can see that that's an issue in general, but particularly with the nurses that are coming out of nursing programs these days. Anyway, I think that's a good example of the application of cognitive therapy, particularly some of Albert Ellis's ideas about masturbation and awfulization and so on. So the role of the therapist, if you're a cognitive therapist, is pretty directive. Now, if you're Albert Ellis, it's very directive because you're really telling people, look, you're stupid, you're an idiot, stop doing this to yourself. This is what you need to do. But Other people would be less directive, but they're still going to steer the patient in cognitive therapy to understand that they're making themselves sick and they need to stop these faulty belief systems. Have plan B in their pocket, for instance, if they don't get into the nursing program or something like that. Some other issues here are that cognitive therapy is particularly useful for depression. I think I mentioned in the last chapter that most research says that it's only the severely depressed that need the medications, and even they need some type of therapy in order to have the best outcomes. It turns out that some form of cognitive therapy is very popular and very successful with people who are depressed today. The truth is that most people who are depressed need to relearn how they think about the world. They have some faulty beliefs. Now, everybody has faulty beliefs. People who have them more are the people that are more likely to be mentally ill, according to this approach. And it's true to a certain extent. All right, that's cognitive therapy, very popular therapy these days. Behavioral therapy is what scientists call a very elegant type of therapy. They say, look, the reason why people are mentally ill is due to faulty learning. People have learned to behave in such a way that creates problems for them, and they just need to unlearn those behaviors. And of course, if a behavior is learned, it can be unlearned. It can be extinguished in the language we learned in chapter 5. You just need to create a contingency of reinforcements and punishments that causes unwanted and inappropriate behaviors to go away and creates the greater likelihood that appropriate behaviors are going to take their place. So what's elegant about this is you don't need to put the person on the couch to analyze all the whys and wherefores of their past. You don't need to examine their subjective feelings and engage in all this kid glove kind of subjective validation and touchy-feely acceptance and empathy and authenticity. All you need to do is find out what behaviors the person is engaging in that are contributing to the problems and eliminate those behaviors or reduce those behaviors through conditioning. You don't even need to get into thinking processes, because to the radical behaviorists, those are also too subjective. But in saying that, I want to point out that a lot of therapists today will use what's called cognitive behavioral therapy. So they'll use the cognitive therapy I just talked about to help change people's thinking processes, make them more healthy, but they'll also engage in behavioral therapy to help them change their behaviors as well. Just because you change behaviors doesn't mean you're also changing the thought processes. And just because you're changing thought processes doesn't mean you're changing behaviors. So the cognitive behavioral therapist today will work on both. But the radical behaviors therapist, who is, or I should say the behavioral therapist that's just using behavioral therapy, would engage in these kind of methods. So there's several methods that behavioral therapists use. The first one that's most popular is systematic desensitization. Systematic desensitization is the most effective therapeutic intervention that anybody has ever created. It's more successful than anything else, and it's probably, in that sense, it's probably 80 to 90% effective, but mostly for therapies, mostly for phobias. So if people have extreme anxious reactions, phobic reactions to things, context to stimuli, then you need to systematically desensitize the patients, the clients, to those things. The way you do it is very gradually. Gradual exposure is another set of words that gets used to describe this. Basically what you do is you find that if the person's afraid of snakes, for instance, you get the person to create a hierarchy from 1 to 10 of all the things, from least to most fear-producing, hierarchy of context or things related to snakes that create fear. And after the person creates the hierarchy with the help of the therapist gets the patient to be totally relaxed, maybe through meditation, yoga, hypnosis, whatever, visual imagery, the person gets totally relaxed, and then the therapist works with the patient to get the patient to imagine and think about number one on the hierarchy. And if the person can think about number one without becoming anxious, then the person moves to number two. If the person can think of number two and imagine that vividly without becoming anxious, then the person moves to number three. If the person becomes anxious at any point, then they move back to the next step, the previous steps, until they can work through all 10 steps, all through parts of the hierarchy without becoming anxious. And once they do that kind of virtually, without the real stimulus, then they can begin to be confronted with the actual stimulus. Maybe the snake is going to be placed in the corner of the room on the other side of the room. And if the person can handle that, then the snake is moved a little closer until finally the snake is right in front of the person. And if there's no anxious reaction, maybe the person puts his hand inside the terrarium, not touching the snake. But if the person can do that, then eventually the person will touch the snake. And gradually the person will overcome the fear of snakes or flying or birds or tests or writing or anything like that people tend to fear. Some people feel like, even though that's very successful, some people feel like that's the kid glove approach. It's too slow, it's too nice. What about the kind of like the Albert Ellis kind of tough love approach? Maybe we could do this a lot more quickly, a lot more effectively if we were a little more rough and a little more directed. So they suggest what's called a flooding or implosion kind of approach. If you fear snakes, then rather take a whole lot of time to gradually expose you to snakes. We're going to take this huge 10-foot long boa constrictor and wrap it around your body. And what's going to happen is we're going to take you to the height of your fear and your anxiety. You're going to feel like you're going to have a heart attack and you're going to hate me. But at the height of your negative experience, there's no place to go but down. So you're going to gradually relax, and then you'll be okay. And we'll solve the problem within a matter of minutes as opposed to days. This is a little bit like the parent that takes the kid and says, you know what, you're not swimming, all your peers are swimming, I just think you're a fraidy cat, you just need to get in there. So the parent picks up the kid and throws the kid in the water, and the kid starts swimming. And the reason why the parent did that is because the parent knew that the kid was likely going to swim. They just needed to get over their fears, and this is the way to quickly do it. So that's called flooding or implosion. It's highly controversial because it can be very traumatic, but it also tends to be fairly effective for some things. Then there's aversive conditioning. We've talked about aversive conditioning in the past with anti-abuse. When you associate, this is a classical conditioning kind of a thing, when you associate drinking or smoking with something aversive, like a rubber band on the wrist that you keep pulling back and hitting your wrist with it, when you associate something like that with smoking, then eventually the thought of smoking or the behavior of smoking becomes associated with something negative to the point that you just don't even want to go there anymore. Rapid smoking is another example of aversive conditioning, where you get somebody to smoke a lot of cigarettes in a very short amount of time to make them sick. Anti-abuse, again, aversive conditioning. This has been used not only with addictions, which is probably the most commonly used and best application for it, but it has been used also for sexual issues. And I just point this out just as an example, not as an ethical way of doing things, and not as an appropriate way of doing things, but just as an example of where this has been applied. So there was a guy that had a secretary that he was having an affair with, and he wanted to stop having the affair. He didn't want to have to be continually aroused by her, yet he didn't want to fire her either. And so he went to the therapist, and the therapist says, okay, what we're going to do is we're going to have you bring in, when you come in next week, a bunch of pictures in erotic poses of your girlfriend, your secretary, and also of your wife. And we're going to give you, say, a certain amount of time with each set of pictures. First of all, we're going to allow you to look at pictures of your wife erotically. And if you become sexually aroused, then fine, we're not going to do anything. You can play that out in whichever way you want. But when you're in another room, in another session, when you're looking at erotic pictures of your secretary and you become sexually aroused, we're going to hook you up to set of wires and a shock machine like Milgram study, and we're going to shock you with a certain amount of voltage of electricity. And we're going to keep doing that until you gradually learn not to be sexually aroused when you're in the presence of your secretary. So that's aversive conditioning to get rid of a sexual arousal state. Supposedly it worked. I'm a little dubious, a little skeptical, but it was reported as being successful. This same therapist also had a patient who said, I'm gay, I have behavioral gay tendencies, I don't want to have those. Can you please condition me to not have those? So then the therapist said, okay, we'll supply the pictures, come in next time, we'll have pictures of naked women, naked men. When you're looking at pictures of naked women, you can become sexually aroused. We're not going to shock you, but if you become sexually aroused when looking at pictures of naked men, we're going to shock you. And supposedly that worked. It was reported as having worked, but as I may have mentioned earlier in this semester, or maybe in chapter 10, just a couple chapters ago, sexual orientation is very hard to change, and most people now think that conversion therapies from homosexuality to heterosexuality do damage to people, and so those things are being outlawed. But back in the day, aversive conditioning was used by some people as a behavioral technique to change somebody's sexual orientation. Probably not ethical, even if it is possible to do that. It's probably not ethical to associate something as natural as the sex drive with shocks, and something so negative just doesn't seem right to me, even, and shouldn't to most people, even if they're adverse to homosexuality. So anyway, I'm not saying that is something that we should do for sure, but it has been done in the past as an example of aversive conditioning. Then there's behavioral modification. So the first three examples of the methods that behaviorists use are all based on the concept of classical conditioning, that associational type of learning. Behavioral modification is the only one of the four that's related to operant conditioning. Operant conditioning, remember, is all about the consequences of our behavior. If my child does this, I'm going to reinforce it. If she does that, I'm going to reinforce it. And in fact, I'm going to chain the child's behavior from this to that, and create a behavior in the long run that the child is not exhibiting at all right now. That's called shaping, and it's in therapy, it's called behavioral modification. It's been used a lot with socially and emotionally disabled children, autistic children that have issues socially and emotionally with other people. They get constantly reinforced by doing things that are more socially acceptable and normative. And the things they do that are conducive to social rejection and things like that, those things tend to get ignored, usually not punished, although in some of these approaches, the punishment has been used. Mostly the programs are adhering to what Skinner believed in, and that is that ignore the bad stuff, reinforce the good stuff, and the good stuff will eventually supplant the bad stuff. Some students that I have this semester, I'm sure, just based on statistics, are working in applied behavioral analysis, which is what they call it, type settings in this area, working with autistic kids and kids like that with behavioral modification, and it tends to be a very successful technique for those kinds of patients and for other kinds of problems in general. Okay. The role of the therapist is pretty directive, not as directive as Freudian therapy, but still pretty directive in that the therapist really needs to put the hands on and basically say, this is what you need to do in order to uncondition this behavior and learn appropriate behaviors. The last issue here is that it's often used along with cognitive therapy, as I already mentioned, and that's what we call cognitive behavioral therapy. So we've talked about psychoanalytic therapy, humanistic therapy, cognitive therapy, and behavioral therapy. 4 different approaches. Most therapists who are successful will probably use all of those to a certain degree when dealing with clients and their particular problems. The research says that they can all be effective. It really depends upon therapist characteristics and the problems that the client is bringing to the therapy situation. But the real question I want to delve into now is, in general, is therapy, whether it's humanistic therapy or psychoanalytic therapy or any other kind of therapy, does it tend to be effective in general? Well, a lot of research has been done on that, partially because clients want to know before they put out money. Research or insurance companies want to know before they put out money whether it's a worthwhile investment. Therapists want to know so that they feel good about their industry. Is this a good industry to go into? Can I feel confident and feel good about the job that I'm doing because it's really going to be beneficial to people? So there's been a lot of research on the effectiveness of therapy, and basically what they found is this broad thing. That is that when you look at people who are having issues, if they don't go through therapy, there's a bell curve distribution of outcomes. Some people get better without therapy. Some people get worse without therapy. Most people stay somewhere in the middle ranges with moderate, mild, or any, if any, change at all in terms of the problems that they initially had over time. If you look at the people who do go through therapy, they also form a bell curve. Some people have really positive results. Some people have pretty negative results, but most people fall somewhere in the middle. So it's the same distribution. It looks the same. But the good news for therapy is that this bell curve distribution is further down toward the good outcome end. More people have better outcomes after they go through therapy than is the case of people who don't go through therapy. In fact, you can actually quantify it. The average person who goes through therapy is better off than all of these people who don't go through therapy, and statistically it's 80%. 80% of the people who don't go through therapy are not as well off as the average person who does go through therapy. And what the research says is that most positive change will occur in therapy after 6 to 8 weeks. And that it doesn't much matter, except for some specific things, it doesn't much matter what kind of therapist or therapy you go to. What really matters is that you connect with that therapist, that you feel like that person cares about you and listens to you, which incidentally is what the humanistic therapist does. So in a way, it does kind of matter that you're going to a humanistic therapist, but most therapists incorporate those techniques these days, even if they're not humanistic in their orientation. All right, I think there's a video on the next slide that has to do with ECT. It's a pretty interesting depiction of ECT and how it might be controversial and yet helpful for some people, the severely depressed with kind of psychotic symptoms. Take a look at that. And of course, we've been talking about medications all semester long. That's the biology side of interventions. You can read about that in the book as well. So that's the class, that's the chapter, that's the class, that's the semester. So I hope it's been a good semester for you and you've learned something. I'll see you around.